So we'll have the speakers come to the front and we'll entertain some questions that you may have for us, and then after that we'll go for a coffee break. Yes.
Hi.
Hi, Paul Haddison, Department of Public Health and Community Medicine. Question about the World Health Organization. You know, in the United States, we face the issue of an incredibly expensive healthcare system and all the resources that we spend in that direction. We know how it plagues us here in this country, but I'm curious, from a World Health Organization perspective, is our net sort of dedication of monies towards medical care and health care, is it a detriment or is it an advantage from the perspective of the WHO when you think about its impact on other countries? So.
Thank you. Difficult question. Well, WHO is not in the business of judging the particular experiences of member states. We haven't taken, as far as I know, a particular position of the goods or less good approach in the American public health system. I would say two things, though. The first is that as a public health institution, very much emphasizes, as I said, population-based public health intervention that are not necessarily medically based. Access to what we call the determinants of health, which are housing, nutritious food, education, things that allow you to be healthy. And the second is that one particular principle, in a way, that we've been pursuing for a while, that become very prominent now, is what we call universal health coverage. The idea that any public health system, whether it's entirely private, entirely public, mixed, whatever if you want, the particular structure, has to guarantee certain basic services to the whole population on a non-discriminatory basis with an eye to equity, so try to taking into account the position of less privileged part of society, and services of a certain quality and affordable. So in a way, rather than addressing the particular features of national health systems, it's more what can be expected of any health system. So that may give you some cue at what, if we were asked, how do you assess the American system, whether it would fit the model or not? Probably not, sort of answer.
Washington Cheng from Harvard School of Public Health. I have one question for Christine and two questions and a comment from Mkaya. So if you would allow me, just ask them together, then I can sit down. For Christine, I'm curious to know from you, I saw that you're doing a lot of work on ART adherence, antiretrovirals. I'm wondering if there is something that we can draw from your experiences in India, the factors that are driving adherence on the positive side. In a study that I'm just concluding in Kenya, we found significant treatment failure of up to about 35%, and that is really worrying us, and we're trying to put down some programs to improve the adherence of the patients. So is there anything you can share with us, what is really helping the adherence from India? And from Mkaya, there's really this good news to see what micronutrient supplementation can do to boost immunity, especially in HIV malnourished individuals. And I know there are a couple of programs that were started before in Kenya. You know, about 11 or so years ago when I was still a small boy, somebody developed a product that they call Vioseed, which really rocked the country, and the guy was traveling all over the place trying to promote the product. The problem is, at some point, it died on the way, so there was the problem of scaling it to a point where it could really benefit the people on the ground to boost their immunity during HIV. So I'm just wondering how you're planning to scale should you finally find that the data shows some significant benefit to the patients. Then the other thing, in your design for the study, you focused on the individuals with fairly good CD4 numbers, healthy individuals. I'm wondering if there is something you can gain or we can gain from using these supplements on people who are already immunocompromised with like CD4s of 200 and below, and then use that as a comparison group. The last comment is drawing from the morning presentation, I think it was by Sabrina, on health literacy. And if there are some Kenyans here that would want to close their ears, I think one of the biggest problems we have now is health literacy on the ground in Kenya. Somebody could be educated with PhD, but they really don't understand the difference from well-being, eating well, eating healthy. Being wealthy in Kenya now is synonymous with eating junky. So I do not know what plans you have, for example, on the ground to be able to circumvent the illiteracy level in terms of health with telling them, trying to cross that bridge and have the people understand that if they take their health as a priority, the education, the knowledge, and then they can be able to use your supplements and any other interventions that you have. What kind of partnership could you be having with Sabrina to be able to improve the health literacy and uptake of the nutritional interventions? Thank you.
Any questions?
Yeah.
You want to start, Chris?
Well, I can start with the adherence, but maybe some of those questions we can take offline and just discuss one-on-one after the meeting. But the issues of adherence, and we've seen the same thing at YRG, that at the end of 6 months, adherence is very good and people are virally suppressed. By the end of a year, it's up to 35% of people who are failing. The trouble with all of these adherence studies is that, it's like every other research project, by the time it gets funded and carried out, the technology has moved on, so that the older studies are less helpful. I think issues that are important are issues of social support or some patient advocate who can encourage the person to continue to take their ART. We've found food insecurity to be a tremendous, if someone is food insecure, then their adherence is much likely to be less. We haven't turned it around and improved food security and demonstrated that will then improve adherence. But I think the other two things that we need to be paying attention to are a lot of the newer combination antiretroviral pills, which not only decrease the pill burden, but decrease the side effect profile, and see where those what the cost effectiveness of those might actually be in preventing fallback to a second or third line therapy. And the other strategy that I think is getting a lot of attention and warrants a lot of attention is the use of mobile devices to be reminding patients to take their medicines or to keep their clinic appointments. So I think there's a lot of work left to be done. I don't think that everything that's useful in India will also be useful in Namibia, will also be useful in South Africa. I think a lot of it will have cultural implications.
Yes. So in terms of the first question, which was on scaling up, right? So I think like the last slide that I had up in terms of what we need to do, now that we've seen that result, we really need to dig deep and really understand what are the mechanisms and how did this work. So we really got to understand on the side of nutrition, what they took in, how did that affect, how did that affect directly or indirectly affect the immune status, really understand that part. And then also understand the social aspect in terms of what are the reliefs that the households had by being given that food that might have enabled them to adhere better to their healthcare seeking behavior and improve that, and if that aspect is an important part. And we're doing this, we're always, almost always, for that purpose, even alluding to what Chris has just mentioned, we always do focus group discussions and try and understand the cultural issues, what's happening in the household, what are the dynamics, so that if we need to scale things up, then we are appropriately doing so, and that is going to work from what happens in the community. The second thing that we've also been incorporating in our research is use of mobile devices and how those can be optimized to help. And I think this also tries to answer the second, was it the second or the third question in terms of improving care and finding out, having mobile devices, having them, remind them not just for the things that they do when they're sick, but also the things that they do to prevent disease, because we know from the economic perspective of many of these households, they can't afford even treatment, and prevention is even further down that priority line. So how can something that they do all the time, they're on their cell phones, they pay, we saw from Professor Kinoti's talk, $7 billion payments for cellular activity in Africa, in several African countries. And so if we can catch that and keep going, I think that's a possible way in which we can use technology to the advantage, since it's already adopted really, really well. I forget the third question of that. But I think we can talk more offline in the interest of time.
I have a quick question for Laura, if I can ask.
Yeah, sure.
You were talking about trying to develop iron fortification plans. And I was just wondering, because iron is such a controversial micronutrient, and particularly in places where there's a high prevalence of HIV and the concern that you'll be actually stimulating the replication of the virus, how do you decide where you supplement and what level of supplementation you use with a micronutrient like that?
Yeah, no, it's a great question, and it's really relevant. There's some general international guidelines we'll use, because fortification is different than supplementation.
Right.
So usually the level of iron that's put into staple foods is low enough that you don't have to worry about that. Now there was the whole malaria and iron fortification issue, which has been addressed. But generally the level that you put in fortified foods is nowhere near the level you get in a supplement. So it's not the same. The fortification world tries to almost mimic what you would get in just an iron-rich diet.
Thank you.
Mm-hmm.
So one more question, yes?
So I guess I want to take an opportunity to say this has been a terrific day with a range of issues that we've addressed. And the question that I have, I think, is probably principally directed to Gian, but others can comment on it as well. And the question has to do with, we know that the shortage of the health workforce, public health professionals and direct providers is a big stumbling block in terms of implementing a lot of the things that we've talked about today, particularly in resource-limited countries. And I know that a few years ago there were some proposals made to address the brain drain of physicians and public health professionals and others from resource-limited countries to actually highly resourced countries, and whether or not to maybe set a fund that essentially reimburses countries that are losing their health professionals to high-income countries. And I know there's also been less maybe a legal approach, and there's been talk about maybe thinking about reverse brain drain, if you will, or sort of employing the something similar to like the Peace Corps, and having folks from high-income countries actually go and serve in the countries that actually are going to be woefully in need of workforce. And I wonder if you can comment on where the WHO sits on that issue.
Okay, thank you. Excellent question. WHO was very involved in this. largely the initiative of the African countries, because obviously they were, in a way, the net losers of doctors and nurses. And there was quite a very political negotiation where 2 or 3 things came up. The first is that the brain drain is not just north to south. There is a lot of movement of nurses and doctors between developing countries. For example, within Africa, South Africa is the main importer of doctors and nurses from the African countries. So it was more complex than just the, if you want, the narrative of the poor South bleeding doctors to the rich North. The second is that I must say many northern countries, European countries, Canada, United States, were very aware of this issue, were a bit on the defensive. They were prepared to do quite a lot, but not to accept like an obligation to compensate. They wanted to stay out almost of an admission of guilt, if you want, of an admission that they had the liability to compensate. So eventually WHO adopted a code, the Health Assembly, so our member states have adopted a code of conduct on the international recruitment of health personnel to address particularly this. It was adopted in 2010. And this code of conduct does 2 or 3 things. The first, it sort of encourages like partnerships at the regional bilateral level between importing and exporting countries. So that staying out of the issue of compensation, or monetary compensation, there could be better, if you want, better terms of the trade. For example, as you said, the reverse brain drain. For example, temporary immigration of doctors that then are committed to go back to the countries, to have like a contractual obligation to go back to the countries. For example, developed countries investing in training in universities of developing countries so that they, at the source, share some of the cost of the brain drain. And the second, to ensure better conditions for the employment of these doctors, because sometimes they are exploited quite badly. And so almost like a human rights, if you want, rights of employment for these doctors and nurses. But the other thing that came out is that the number of countries, first and foremost the Philippines, that actually train on purpose a surplus of nurses to export them. These nurses, Filipino nurses, are all over the world because basically their country encourages them to go abroad because they're a main source of remittals, which are probably 30 to 40% of the economy of the Philippines. So you also have, in a way, a voluntary brain drain, or countries that have evidently a solid tradition of nursing, and they do export them as a source of income. So it's quite complicated. But so this code of conduct is a bit, if you want, like a blueprint. But there are other codes of conduct, for example, within the Commonwealth. The Commonwealth has adopted its own code for the exchanges of doctors and nurses within the Commonwealth countries. So you have a number of initiatives to address this.
Okay, so I think with that we will take a coffee break and come back after 15 minutes for synthesis and discussion of today's meetings. Thank you very much.